Usually when we talk about a medical diagnosis, there's this expectation of precision.
Right, like a kind of engineering.
Yeah,
Yeah,
exactly. Like
yeah.
you break your arm, the x-ray shows that jagged white line, the doctor points to it, and there it is.
Broken or not broken.
Right. The path forward is just clean and
It
obvious.
is a very comforting expectation. I mean, we naturally want our biology to be visible and, neatly categorized,
And easily fixed. But then you step away from the x-ray machine and into the world of women's intimate health.
which is a completely different landscape.
It really is. Specifically, we are doing a deep dive today into a topic that is incredibly crucial. I mean, it affects millions of people, yet it remains heavily shrouded in taboo and misunderstanding.
And misdiagnosis, unfortunately.
Yeah, big time. We are looking at changes in vulvar architecture today, and I have a massive stack of research on the table in front of me.
It's a pretty dense pile of literature.
It is. We've got clinical guidelines from the Australian Journal of General Practice, surgical insights, data on dermatological fillers, and these highly specialized vulvovaginal atlases.
Right, the visual references.
Yeah. So, okay, let's unpack this. Our mission today is to figure out how clinicians actually tell the difference between the simple aesthetic volume loss, menopausal atrophy, and a highly destructive skin condition like lichen sclerosis.
Because just looking at the symptom lists on paper, the overlap is genuinely intimidating.
It really is. I mean, they all sound so similar if you just read the bullet points.
They do. And the stakes here are remarkably high. You're dealing with conditions that share very common superficial symptoms.
Like what specifically?
Well, a patient might come in reporting discomfort or visible changes to the tissue, maybe some dryness or friction,
Right.
but the underlying biology of what is actually happening at a cellular level is vastly different for each of those three categories.
So if a clinician misreads the landscape, what happens? Like if they confuse a structural aging process with an autoimmune disease?
The treatments they prescribe will be entirely ineffective. I mean, in some cases, misinterpreting the physical signs can lead to unnecessary, irreversible surgeries.
Oh, wow.
Yeah, or leave a patient at an elevated risk for malignancy.
Okay, that is serious. So let's ground this by looking at the first major clinical presentation. This one revolves purely around structure and volume.
Right, what we call aesthetic labial deflation.
Deflation. So we're talking about changes that happen as women age or go through natural menopause or even experience significant weight loss.
Yes,
Right.
exactly. The core issue here is lipotrophy. But to understand this, we need a quick anatomical baseline.
Okay, lay it to me.
So the outer lips, the labia majora, are functionally a facial analog.
Wait, like the face?
Yeah, they are covered in regular keratinized skin, which means it has that tough, waterproof outer layer of keratin, much like the skin on your arm or your face.
Okay, I see.
In youth, they are full and smooth, and that's created by a subcutaneous fatty tissue that forms an inverted V shape.
What a protective pad.
Exactly. This fat pad offers vital protection and cushioning to the more delicate inner structures.
But then during aging or after significant weight loss, that fat literally just melts away.
It does. The dermis loses its tension, and the structural envelope essentially just empties out.
It's kind of like letting the air out of a bicycle tire
That's a good way to put it.
or like losing the padding in a couch cushion. Suddenly the fabric on the outside gets all wrinkly and lax because the stuffing is just gone.
That is a highly accurate way to visualize it. And this leads to a really fascinating clinical phenomenon known as pseudoprotrusion.
Okay, I saw this term popping up in the sources, and it kind of blew my mind because of the surgical implications.
It's a huge issue in clinical practice.
Can you walk through what pseudoprotrusion actually looks like to the patient? Because it sounds like something is actively growing, but that's not the reality.
Right. It is an optical illusion of sorts. The inner lips, the labia minora, and the clitoral hood haven't actually grown or changed their dimensions at all.
They're exactly the same size they always were.
Exactly. But because that outer cushion of the majora has deflated and receded, the inner structures are suddenly unveiled.
Oh, I get it. So they were previously tucked behind those full outer lips.
Yes. Now, stripped of that structural envelope, they just stick out.
And that lack of cushioning leads to friction against clothing, right?
It does. Severe discomfort during sports like cycling and pain during sexual intercourse.
Which brings up a critical question regarding patient care. If a patient comes into a clinic complaining that their labia minora are suddenly too long, or that they're protruding and causing all this friction.
Which is a very common complaint.
Right. Are they at risk of getting unnecessary surgeries? Like, are surgeons performing labiaplasties to cut the minora down when the real issue is just a deflated majora?
Sadly, yes. This is a major clinical pitfall.
That's wild.
A patient presents with what looks like minora excess, but a proper diagnostic evaluation of the architecture reveals it's purely a majora volume problem.
So if a surgeon simply reduces the minora in that patient, they are cutting away entirely healthy tissue.
Exactly. They can worsen the aesthetic appearance and functionally overcorrect a structure that was never the primary issue to begin with.
You're basically permanently amputating a normal structure instead of just fixing the flat tire.
That's a perfect analogy.
So what is the anatomically honest fix for this specific type of deflation?
Volume restoration. The clinical field has moved heavily toward using hyaluronic acid, or HA fillers.
Like the kind they use in faces.
Exactly the same concept. As well as autologous fat transfers, which is moving fat from the patient's own thigh or abdomen.
Wow. Right.
HA fillers are particularly interesting because hyaluronic acid is a naturally occurring molecule in the body.
And it acts like a sponge, right? Attracting and holding on to water.
You've got it. When injected into the deflated labia majora, it rebuilds that structural scaffold.
And the data on this is really compelling. One of the randomized controlled studies in our stack involved 76 women with labia majora hypertrophy.
Which is that volume loss we're talking about.
Right. Half got the HA filler, half didn't.
And the results were striking.
At the 6-month mark, the treated group had massively improved scores on the Female Sexual Function Index.
Their pain decreased, satisfaction increased, and there were no serious adverse events.
It seems like a minimally invasive way to just pump up that couch cushion again and resolve the friction.
It resolves the physical mechanics of the friction perfectly. But it only works if the only problem is that missing cushion.
Right. Which brings us to the second major clinical category. And this is where the diagnostic waters get much deeper.
Because we're no longer just talking about structural padding.
Exactly. Aesthetic deflation is just about the structural padding. But what happens when the actual hormonal fuel that keeps this entire bodily system running just disappears?
Then we enter the territory of genitourinary syndrome of menopause.
Or GSM, for short.
Right, GSM. The older terminology for this was atrophic vaginitis, but GSM is a much more comprehensive and accurate term.
And this condition is strictly tied to low estrogen states, right?
It is. Natural menopause is the most common driver. But we also see it in postpartum women, during lactation, or in patients undergoing anti-estrogen therapies for breast cancer.
Looking at the clinical breakdown here, the biggest differentiator between this and the first issue is geography.
Geography is key here, yes.
Because the aesthetic deflation we just talked about is restricted to the outside envelope. It doesn't change the internal vaginal canal.
Right.
But GSM attacks both the outside and the inside.
Yes, and it's doing it because the estrogen drought causes the internal vaginal epithelium to undergo a massive systemic shift.
To appreciate the severity of that shift, you really have to understand the microenvironment of a healthy premenopausal vagina.
You do. The internal vaginal canal is made of non-keratinized mucosal tissue.
So unlike the outside, it doesn't have that tough waterproof layer.
Exactly. It is designed to be plump, highly elastic, and acidic.
And it has these deep folds called rugae, right?
Yes, the rugae. They act almost like the pleats of an accordion.
Which allows the tissue to stretch and expand mechanically without tearing.
Precisely. And estrogen is essentially the master regulator of that entire accordion.
It absolutely is.
Yeah.
Estrogen stimulates the maturation of vaginal epithelial cells.
Okay, so when estrogen levels are robust, what happens?
These cells mature all the way to the superficial layer, becoming rich in a sugar called glycogen.
Glycogen, okay.
And as these cells naturally slough off into the vaginal canal, lactobacilli, the beneficial bacteria in the vagina, feed on that glycogen.
So they eat the sugar.
Right. And as they metabolize the glycogen, they produce lactic acid.
Oh, I see.
That constant production of lactic acid keeps the vaginal pH acidic, usually between 3.5 and 4.5.
So it's an entirely self-sustaining, localized ecosystem. The estrogen feeds the cells feed the good bacteria, and the good bacteria create an acidic force field.
That's a great way to describe it.
And that force field keeps the tissue healthy and blocks out pathogens.
Exactly.
But when you turn off the estrogen tap, that whole production line just shuts down.
The maturation process completely stalls. The cells no longer make it to that glycogen-rich superficial stage.
So because there's no glycogen, the lactobacilli literally starve to death.
They do. And the lactic acid disappears, and the vaginal pH spikes above 4.5, becoming increasingly alkaline.
Which totally changes what a clinician sees during an exam. The visual signs of this are incredibly stark.
They are very clear if you know what to look for.
Instead of being plump and pink, the internal tissue becomes pale, dry, smooth, and shiny.
Because those accordion folds, the rugae, physically flatten out.
Right. You also see petechiae, which are these pinpoint purple-red blood spots.
Yes. The tissue becomes so fragile that just the friction of an exam can expose and break the subepithelial blood vessels.
That sounds incredibly painful. And it's not just the inside, right? On the outside, the labia majora contract, pubic hair thins, and the clitoral hood can retract.
Which leaves the glands painfully exposed and sensitive.
So this is where the treatment protocol completely diverges from our first category. You cannot fix GSM with a hyaluronic acid filler.
No, absolutely not. An HA filler might cosmetically plump the outer labia majora, but it does absolutely nothing to restore that complex cellular maturation process.
Or the glycogen production, or the pH balance.
Right, because it's a tissue health problem, not a volume problem.
You need to restart the factory, not just pad the walls.
Exactly. So the gold standard here is bringing the hormone back to the tissue.
Local vaginal estrogen therapy.
Or DHEA inserts. They are incredibly effective. They restore the hormonal signaling locally without causing systemic spikes in the patient's overall bloodstream.
But I also noticed the clinical guidelines discussing energy-based treatments for GSM, specifically fractional CO2 lasers.
Yes, that's a newer modality.
And I have to push back on this a little bit. If a patient has incredibly fragile, painful, thinned-out tissue, how does shooting a highly powered laser into that tissue to cause burns actually help them?
It does sound completely counterintuitive.
It sounds aggressive.
It does, but the key word here is fractional. The laser is not burning a solid sheet of tissue.
Oh.
It creates a microscopic grid of controlled microtrauma. So tiny pinpoint thermal columns spaced out across the tissue, leaving healthy tissue between.
So you are deliberately injuring the tissue, but just a tiny bit.
Exactly enough to trick the body's emergency repair systems into activating.
Oh, that makes sense.
The microtrauma triggers fibroblasts, which are the cells responsible for structural framework, to rush to the area.
Right.
It stimulates angiogenesis, which is the formation of fresh new blood vessels. It forces the body to lay down new, healthy collagen and elastin.
So by causing a very specific controlled injury, the laser effectively wakes up the dormant atrophic tissue.
Yes, thickening the epithelium and restoring elasticity without relying entirely on hormones.
That is fascinating. Okay, so we have the deflated cushion, which is purely structural volume loss.
Right.
We have the estrogen drought of GSM, which thins everything out and destroys the internal acidic ecosystem.
Yeah,
But now we have to look at the third condition in this clinical puzzle. And honestly, this one carries the most gravity.
It really does.
What happens if a patient has extreme discomfort, but it isn't just aging, and it isn't a lack of estrogen? What if the tissue is under an active, destructive, inflammatory attack?
Then you are describing lichen sclerosis, or LS.
LS?
Right. This is a chronic inflammatory dermatosis. While the exact pathogenesis is still being heavily researched, it is deeply tied to the autoimmune system.
Right, because we frequently see it appearing alongside other autoimmune conditions.
Yes, like thyroid disease or vitiligo. And we really must highlight a sobering statistic here.
The cancer risk.
Yes. Untreated lichen sclerosis carries a 5 to 6% lifetime risk of developing into squamous cell carcinoma.
Which makes accurate diagnosis an absolute imperative. I mean, we are no longer just talking about sexual comfort or athletic friction here.
No, we are talking about active cancer prevention.
And the visual hallmarks of LS are very distinct once you know what you are looking at based on the atlases.
They are. The tissue presents with these porcelain white papules.
And the skin becomes so intensely thin and crinkled that dermatologists actually refer to it as cigarette paper skin.
That's the clinical description, yes.
Yeah.
And it often appears in a very well-demarcated white patch, forming a figure-of-8 pattern that encircles the vulva and the anus.
And this brings us to the most critical clinical differentiator of all, which is anatomical geography again.
Geography is everything here.
We just discussed how the estrogen drought of GSM affects both the external vulva and the internal vaginal canal.
Right.
But lichen sclerosis, however, has a hard anatomical boundary.
It never involves the skin above the hymenal ring. It does not affect the inside of the vagina.
That is such a vital piece of the puzzle for anyone trying to figure out what is happening to their body.
It's a huge diagnostic clue.
Because if a clinician uses a speculum and sees an atrophic, smooth, pale internal vagina, they are looking at a hormonal issue, like GSM.
Exactly.
But if the internal vagina is healthy, pink, and rugated, while the outside vulva is scarred and white, they are likely looking at an autoimmune attack, LS.
Yes, and the symptoms also carry unique signatures.
Right, the itching.
While both GSM and LS can cause itching, the hallmark of lichen sclerosus is severe, intractable vulvar itching that is specifically and maddeningly worse at night.
Worse at night. And unlike the other two conditions, LS actively destroys the architecture of the vulva.
It does. With the aesthetic deflation we talked about earlier, the inner lips were just unveiled.
Right, they just stuck out.
But with LS, the inflammation causes scarring that physically erases the anatomy.
Oh, wow.
The labia minora don't just shrink, they can completely resorb into the surrounding tissue or fuse together in a process called synechia.
The architectural destruction can be profound and devastating for the patient. I read that the prepuce, or the clitoral hood, can scar and fuse to the point where the clitoris becomes entirely buried.
Under dense scar tissue, yes, that's a condition known as clitoral phimosis, which can cause intense neuropathic pain,
And the scarring can also aggressively narrow the introitus, the vaginal opening.
making intercourse completely impossible and sometimes even impeding the flow of urine.
I have to ask the obvious, dangerous question here.
Go ahead.
Let's say a 55-year-old patient comes into a clinic. She is menopausal. She is experiencing terrible itching and noticing tissue changes.
A very standard presentation.
And the clinician assumes, purely based on her age, that it is just GSM, the estrogen drought.
Right.
So they prescribe a basic local estrogen cream. Will that estrogen cream fix the lichen sclerosus?
Emphatically, no. Estrogen will do absolutely nothing to halt the progression of lichen sclerosus.
And this is exactly why establishing these strict clinical criteria matters so deeply.
It does. LS is driven by an overactive, localized immune response attacking the tissue. The immune system does not care how much estrogen you apply to the area.
To stop the scarring, reverse the inflammation, and mitigate that 5 to 6% risk of squamous cell carcinoma, LS requires lifelong suppression of the immune response in that specific tissue.
And the gold standard for doing that is ultrapotent topical corticosteroids.
Specifically, ointments like clobetasol propionate.
Right, and this requires a massive paradigm shift for the patient and the provider.
Because it's a lifelong commitment.
The consensus is now lifelong maintenance therapy. Even when the patient is completely asymptomatic and feels perfectly fine, they must apply the steroid ointment once or twice a week.
Just to keep the disease suppressed at a cellular level and prevent the mutations that lead to cancer.
Exactly.
Which brings up a massive hurdle in patient compliance. Steroid phobia.
It's a very real hurdle.
We are constantly told not to use topical steroids for too long because they will thin the skin.
Right.
So patients see this cigarette paper thin skin caused by the LS and they are terrified that applying a strong steroid will thin it even more.
It is a completely understandable fear, but it is biologically backwards in this context.
How so?
Well, in the case of lichen sclerosus, it is the unchecked inflammation of the disease that is causing the pathological thinning and scarring of the tissue.
Oh, I see.
The ultrapotent steroid stops the inflammation, which actually allows the skin to heal and regain its normal thickness. The steroid is the protector, not the destroyer.
Okay, so if you are listening to this and you are trying to advocate for your own health at your next doctor's appointment, or perhaps you're a clinician trying to refine your diagnostic eye, the best tool you have is mapping the geography of the symptoms.
Geography is everything.
You don't have to be a medical expert to advocate for yourself if you know where to look.
Right.
If the issue is just friction, the outer lips look wrinkly and deflated, but the skin color is perfectly normal, the inside feels normal, and there's no crazy itching.
That points to volume loss.
Exactly. You might just need structural support, like an HA filler.
And if you are experiencing profound dryness, burning, and pain during sex, and you notice your natural lubrication is completely gone, that points inward.
If the internal tissue is pale and smooth, and a doctor tests your pH and it's high, that points to an estrogen drought.
That requires hormonal or cellular restoration.
But if you are experiencing extreme, maddening itching that wakes you up at night, and you look with a mirror and see porcelain white patches on the outside, or you notice your inner lips are starting to fuse or disappear, while the internal vagina feels totally fine.
That is a massive red flag for lichen sclerosis.
That requires immediate specialist review, potentially a biopsy, and dedicated steroid treatment to protect your anatomy and your long-term health.
The overarching message is to never assume that severe vulvar pain or intractable itching is just a normal part of menopause.
Right. We often homogenize women's pain, grouping it all under the umbrella of just getting older.
We really do.
Yeah.
But if you have itching or tissue changes that persist past 6 weeks and they do not respond to basic estrogen therapy or over-the-counter moisturizers, you must demand a deeper look.
Breaking down these criteria really forces both patients and doctors to respect the profound complexity of vulvar biology.
It does.
It is such an empowering lens to view this through. Thank you for acting as the ultimate guide through this deeply complex landscape. You really helped translate a very intimidating stack of medical data into a real compass for our listeners.
Well, it is a conversation that desperately needs to happen more often.
Yeah.
And looking across all these different physiological mechanisms, it actually raises a lingering mystery that the medical community still hasn't fully solved.
I love a good biological mystery. What is it?
Well, we established that lichen sclerosis is a systemic autoimmune-driven condition.
Right.
And yet, as we discussed, it strictly, almost perfectly, respects the anatomical boundary of the hymenal ring.
Right. It stops exactly at the entrance to the vagina.
It will aggressively destroy the outer vulva, but it stops there. Why does the immune system relentlessly attack the keratinized, tough skin of the outer vulva in that perfect figure-of-8 pattern, but completely ignore the non-keratinized soft mucosal tissue just millimeters away?
Yeah.
It's a profound biological mystery about how our immune cells recognize territory, how they draw these microscopic borders and decide what to attack and what to spare.
That is wild to think about, just millimeters away, and the immune system treats it like an entirely different country.
It really makes you appreciate the incredible, almost unfathomable complexity of the human body.
It does. We started this deep dive talking about how comforting it is when a diagnosis is like an X-ray, a clean, binary, broken or not broken picture.
Right.
But as we've explored today, the reality of vulvar health isn't a black and white photograph. It is a highly dynamic, living ecosystem driven by fat pads, estrogen receptors, bacterial microbiomes, and immune system borders.
It is constantly shifting.
We might not have a simple X-ray for it, but with the right clinical criteria and a willingness to ask the deeper questions, the picture finally comes into focus.